Hi, I'm Dr. Ray Stetson. I'm a senior associate consultant, assistant professor of pediatrics, and clinical neonatologist at the Mayo Clinic in Rochester, Minnesota, in the United States of America. Today we're going to be discussing non-invasive ventilation in newborns, a truly hot topic in neonatal medicine for nearly 50 years. I don't have any financial disclosures or conflicts of interest pertinent to this topic. However, we will be discussing several FDA-approved and non-FDA-approved devices and the use of non-invasive ventilation and surfactant administration in newborns. We'll have three primary learning objectives. First, we'll review the historical context of non-invasive ventilation use in newborns with respiratory distress syndrome. Second, we'll discuss non-invasive ventilation devices, modalities, and their effects on neonatal outcomes. Finally, we're going to review trends in the use of non-invasive ventilation in newborns and trends in neonatal outcomes. Infants with respiratory distress syndrome have insufficient surfactant, which leads to atelectasis, decreased functional residual capacity, and decreased lung compliance. In non-invasive ventilation strategies, this is treated with positive airway pressure, which helps to overcome atelectasis and increase functional residual capacity to increase the infant's ability to oxygenate and ventilate. The first use of endotracheal continuous positive airway pressure was described in 1971 by George Gregory and colleagues at the University of California, San Francisco. They reported a case series of 18 infants with respiratory distress syndrome treated with continuous positive airway pressure delivered by an endotracheal tube with reports of improved oxygenation and survival. In the same study, Gregory and colleagues also described the use of the first non-invasive delivery of CPAP. This was accomplished by use of a device that would go on to be called the Gregory box. They used this Gregory box to support 2 infants, and this device consisted of a chamber that was closed around the infant's head and sealed around their neck. This allowed generation of positive airway pressure and installation of supplemental oxygen. Dunn and others would go on to report improved survival in case series of infants with respiratory distress syndrome using similar devices to the Gregory box. In the following years, further innovation of devices to non-invasively deliver CPAP to infants with respiratory distress syndrome were developed, eventually leading to the face masks, nasal prongs, and nasal masks utilized in modern neonatal practices. In the late 1980s, there was a growing level of interest in identifying exposures and treatment modalities associated with improved neonatal outcomes for premature infants, including increased survival to NICU discharge and decreased morbidity for conditions such as bronchopulmonary dysplasia. In 1987, Avery and colleagues performed a survey of 8 large neonatal intensive care units, with 7 of the units located in the United States and 1 unit located in Canada. They sought to determine these factors related to better infant survival for premature infants and decreased morbidities. This study included over 1,600 infants with birth weights between 700 and 1,500 grams. Avery noted that center number 3 in this survey, which corresponded to Columbia University, had both one of the highest rates of survival to NICU discharge, as well as the lowest rate of bronchopulmonary dysplasia reported of any of the 8 centers which were surveyed. Bronchopulmonary dysplasia was defined in this study as oxygen dependence at 28 days of age. Compared to the other centers, Columbia had much higher usage rates of non-invasive ventilation, which they supplied by nasal bubble CPAP. They also had much lower rates of mechanical ventilation. This sparked an era of innovation and interest in utilizing non-invasive ventilation strategies in the care of premature infants with respiratory distress syndrome. Nasal CPAP can be administered non-invasively to infants, either via bubble CPAP circuits or ventilator-driven CPAP circuits. In either case, the continuous positive airway pressure is delivered to the upper airways through tubing and interfaces with the infant's nares, either through nasal cannula or nasal masks. Ventilator-driven CPAP tends to deliver a more consistent level of CPAP, while bubble CPAP tends to generate variable descending pressure, sometimes called the noise of bubble CPAP. Each system has its benefits and drawbacks. Bubble CPAP systems can be more cost-effective to implement, and many take up smaller footprints in the infant's care room when compared to ventilator-driven CPAP. Ventilators may offer clinicians more versatility in ventilation options. This includes the ability of some systems to also perform nasal intermittent positive pressure ventilation. Additionally, if infants' respiratory status decompensates and they require intubation, the same ventilator can often be used to deliver mechanical ventilation. Nasal intermittent positive pressure ventilation is another non-invasive ventilation strategy available to support infants with respiratory distress syndrome. Nasal intermittent positive pressure ventilation involves providing a continuous positive airway pressure along with intermittent higher ventilator provided pressures or breaths. These additional intermittent breaths can either be synchronized to the patient's respiratory status or delivered asynchronously. A 2017 Cochrane review found that premature infants with respiratory distress syndrome who were extubated to nasal intermittent positive pressure ventilation rather than nasal CPAP had lower rates of reintubation. A concern arose following the development of nasal intermittent positive pressure ventilation that there may be more GI side effects related to asynchronous breaths being delivered when the infant's glottis was closed, causing distension of the esophagus and stomach. However, in this same 2017 Cochrane review, the researchers noted that there were similar rates reported in the literature of necrotizing enterocolitis, gastric perforation, or cessation of feeds due to abdominal distension in infants treated with either nasal intermittent positive pressure ventilation or nasal CPAP. Heated and humidified high-flow nasal cannula provide distending pressure to achieve non-invasive ventilation by delivering a set amount of gas flow and allowing variations in airway pressure. In neonatal practice, these flow rates typically range from 1 to 10 liters per minute. High-flow nasal cannula can be administered either with locally made systems, commercial high-flow nasal cannula with specific products, or by a subset of mechanical ventilators. High-flow nasal cannula systems have fluctuating airway pressure, and all systems require a pressure pop-off valve for patient safety. When the cannula are occluded, very high airway pressures can be recorded if a pressure pop-off valve is not in place. Wilkinson et al. Described an equation to estimate pharyngeal pressures based on high-flow nasal cannula flow rates and patient weights. They also described similar airway pressure measurements for patients treated with high-flow nasal cannula when their mouths were open versus when they were closed. Initially, high-flow nasal cannula was also thought to perhaps be a more cost-effective method of delivering non-invasive respiratory support to infants when compared to nasal CPAP. However, a recent study from Australian researchers found that high-flow nasal cannula systems in special care nurseries were actually more costly than systems that had nasal CPAP as the primary non-invasive ventilation support. However, approaches in systems that use high-flow nasal cannula with nasal CPAP backup were found to have similar cost effectiveness in this study to units that used just nasal CPAP. Nasal breakdown is also a concern for infants supported with non-invasive ventilation. Not only can nasal breakdown cause patients pain and discomfort, but if it progresses, it may limit the ability to continue use of non-invasive ventilation, and invasive ventilation may need to be pursued in order to allow healing of the nasal breakdown. Additionally, for a subset of patients with severe nasal breakdown, surgical repair may be required. A recent systematic review of 45 studies found that nasal injury is common in patients treated with non-invasive ventilation, with rates ranging from 20% to up to 100% depending on the study. Factors that make nasal injury more common include use of binasal prongs or patient gestational age less than 30 weeks, use of masks rather than prongs, nasal barriers, or high-flow nasal cannula rather than nasal prongs were all found to be protective against nasal injury in infants treated with non-invasive ventilation. Evidence is currently lacking to guide a consensus approach in weaning nasal CPAP. Nasal CPAP duration must be a balance between patient benefits, which include increased functional residual capacity and lung function, upper airway splinting for infants with airway malacia, and reduced caloric expenditure for work of breathing, with the potential adverse effects of nasal CPAP, which can include decreased venous return and cardiac function secondary to high thoracic pressures, abdominal distension and feeding intolerance, delayed oral feeding initiation, and nasal injury. Commonly, weaning timing is based on patient gestational age, work of breathing, supplemental oxygen needs, chest radiograph patterns, tolerance of empiric support weans, and sometimes patient weight. Additionally, there are various approaches to weaning CPAP support, which can include incremental decreases in the CPAP pressure versus cycling infants on and off CPAP support for gradually longer periods of time. In the early 2000s and 2010s, high-flow nasal cannula was emerging as a more common modality for non-invasive ventilation support of newborns with respiratory distress syndrome. However, there was evidence lacking on its efficacy compared to nasal CPAP in treating infants with respiratory distress syndrome. In 2016, Roberts and colleagues reported a large international randomized controlled trial of over 500 preterm infants who were greater than 28 weeks of postmenstrual age who had respiratory distress syndrome who were randomized to either primary treatment with nasal CPAP or high-flow nasal cannula. Of note, this randomization occurred immediately after delivery, and infants had not received surfactant therapy prior to randomization. The primary outcome of this study was treatment failure within 72 hours. This was defined as progression to nasal CPAP or intubation for the high-flow nasal cannula arm, or progression to intubation for the CPAP arm. Higher rates of treatment failure were observed in the high-flow nasal cannula arm of the study, with a trend towards higher rates of intubation in the study arm as well. The trial was actually stopped early by the Data and Safety Monitoring Committee due to the discrepancies in outcomes, with the CPAP arm having more favorable respiratory outcomes. As non-invasive ventilation techniques have increasingly been used to support infants with respiratory distress syndrome cared for in NICUs, investigators have been focused on optimal respiratory care for infants in the delivery room as well. In 2010, researchers from the Neonatal Research Network performed a trial dubbed the SUPPORT trial. This randomized multi-center trial included over 1,300 infants examining intubation and surfactant administration within the first hour of life versus initial respiratory support with nasal CPAP. Study subjects ranged from 24 to 27 and 6/7 weeks of gestational age at enrollment. The investigators found that both study arms had similar rates of their combined primary outcome of death or bronchopulmonary dysplasia. Infants initially treated with nasal CPAP had lower rates of intubation, days of mechanical ventilation, or receipt of postnatal steroids for treatment of bronchopulmonary dysplasia. Researchers in the Australia-Asian Trial Network performed a similar study called the CPAP or intubation, also known as the COIN trial. In this study, over 600 infants were randomized to either delivery room nasal CPAP or intubation. Of note, unlike the SUPPORT trial, infants in the intubation arm were not universally administered early surfactant per the COIN trial protocol. A non-significant trend towards lower rates of BPD or death at 36 weeks was noted in the CPAP arm. However, higher rates of pneumothorax were also noted in the CPAP arm. A trial conducted by the Vermont-Oxford Network in the United States randomly assigned infants to one of 3 treatment arms. These included prophylactic surfactant administration and extubation to nasal CPAP, or primary support with nasal CPAP. There was no significant difference in this study between these 3 treatment arms for their primary outcome of bronchopulmonary dysplasia or death at 36 weeks. The South American Neocosur Network performed a trial comparing initial support with nasal CPAP versus oxygen hood, with a trend towards lower rates of bronchopulmonary dysplasia in the nasal CPAP arm of this study. Several strategies and techniques have been developed to administer surfactant to infants with respiratory distress without exposing infants to mechanical ventilation or minimizing the duration of mechanical ventilation exposure. The intubate surfactant extubation, also known as ensure technique, involves intubating infants, administering surfactant, and then extubating to non-invasive ventilation support. Techniques have also been developed, such as the less invasive surfactant administration, or LISA technique, to instill surfactant through a thin catheter while the infant is spontaneously breathing and avoid the need for endotracheal intubation. The LISA technique for surfactant administration is more widely used in Europe, the Middle East, Australia, and parts of Southeast Asia than compared to the United States. A 2018 survey of neonatologists practicing in the United States found that only 15% utilized the LISA technique in their clinical practice, and nearly half of these neonatologists were utilizing the LISA technique as part of a research study. Nebulized and atomized surfactant administration has been described in animal models as early as the 1990s. Several randomized clinical trials have been performed assessing the efficacy of aerosolized surfactant. The current Aerofact 2B trial is currently enrolling and comparing nasal CPAP alone versus nasal CPAP and aerosolized surfactant administration. Earlier this year, Hatch and colleagues reported on trends in initial respiratory support modalities for infants cared for in NICUs across the United States. Their study utilized two large databases and included over 250,000 subjects across over 350 NICUs. Their study period looked at the years 2008 to 2018. Over this 10-year period, a significant increase in the use of nasal intermittent positive pressure ventilation and nasal CPAP was noted, along with a concomitant decline in the use of mechanical ventilation. Overall rates of non-invasive ventilation support rose from 58% in 2008 to over 67% in 2018. Mechanical ventilation use during the same period declined from 22% in 2008 to 18.5% in 2018. In the same study, Hatch and his co-investigators found that the duration of positive pressure support increased during the study period by an average of 3.2 days per patient. This trend was noted in nearly all examined gestational age groups. Additionally, the trends of increased non-invasive ventilation support and declined use of mechanical ventilation were consistent across all examined gestational age groups. Even the youngest gestational age group of 23 to 25 weeks had an increase in non-invasive ventilation support of over 50% of the subjects. Hatch et al. Also looked at differences in the expected mechanical ventilation use based on 2008 practices and patient characteristics noted across the study period, and the observed mechanical ventilation use that they saw in their study. Based on these differences in observed to expected mechanical ventilation use, they noted that an estimated 29,700 fewer infants were exposed to mechanical ventilation, secondary to the changes in trends in increased non-invasive ventilation use and decreased mechanical ventilation use during the study epoch. This resulted in an estimated 142,000 fewer days of mechanical ventilation for patients during the study period. Despite the significant advances that have been made to respiratory management of premature infants with respiratory distress syndrome, both from non-invasive ventilation and invasive ventilation modalities, complications from respiratory distress and bronchopulmonary dysplasia still account for a large amount of the mortality observed in neonatal intensive care units. A recent cohort study found that in the first 2 weeks of life, nearly half of all deaths are secondary to respiratory distress syndrome. In the first month of life, respiratory distress syndrome still accounts for 43% of observed deaths in NICU infants. For infants hospitalized in NICUs for over 2 months, complications from bronchopulmonary dysplasia are the leading cause of death. This highlights that while we've made significant advances in the field of respiratory support for premature infants, this is still an area that needs more innovation and research. I think it's also important to remember that bronchopulmonary dysplasia affects more outcomes for premature infants than just their survival or respiratory status. In a retrospective cohort study utilizing NICHD neonatal research network data from patients cared for from the years 2006 to 2010, Zhang and colleagues found an increased risk for neurodevelopmental impairment at 18 to 22 months for infants who received prolonged respiratory support. Infants who received only invasive respiratory support had the highest rate of neurodevelopmental impairment at 18 to 22 months at nearly 90%. This was followed by infants whose support was a mix of invasive and non-invasive support, who had a 26.1% rate of neurodevelopmental impairment at 18 to 22 months. Infants who only required non-invasive support had the best neurodevelopmental outcome in this study, with only 7.7% having neurodevelopmental impairment noted at 18 to 22 months. Despite the increased trend in usage of non-invasive ventilation support strategies, the decreased trend in the use of mechanical ventilation, and the increased use of surfactant therapy in the treatment of respiratory distress syndrome for infants, a recent cohort study of over 34,000 infants who were born between 22 and 28 weeks gestational age, with birth weights ranging from 400 to 1,500 grams, found stable to increasing rates of bronchopulmonary dysplasia. The study period ranged from 1992 to 2012. Further, a study of pulmonary function in children who had been born prematurely had similarly concerning findings. In this study, they examined the pulmonary function status at 8 years of age for children who had been born at less than 28 weeks of gestation. Surprisingly, it was the most modern epoch of children who actually had the worst pulmonary function at 8 years. This is despite the fact that this epoch of children was exposed to lower rates of mechanical ventilation and higher rates of non-invasive ventilation support. These findings highlight that bronchopulmonary dysplasia is a complex disease process and that we need to examine near-term, medium-term, and long-term outcomes when considering respiratory support management for these patients. Thank you for the invitation to present this very interesting subject in neonatal medicine. I'm including this slide to reference the papers discussed in this presentation. Additionally, each reference is included on the bottom of the slide where it is first mentioned. I look forward to your questions during our panel discussion.